For our next talk, we'll switch gears a little bit and look at AMR in the built environment. And so with that, I'd like to invite the next two speakers. First, Dr. Carolyn Nott, who is an infectious disease physician at the Ottawa Hospital, also medical director of the Antimicrobial Stewardship Program and the chair of the Antimicrobial Subcommittee of the Pharmacy and Therapeutics Committee. And she's the PI of the CUBE project since its inception. With that, also Dr. Derek MacFadden, also from the Ottawa Hospital, and he's a junior clinical research chair in antimicrobial use and resistance. So thank you both.
Thank you so much. We're both really pleased to be able to speak to you today about what we think is a bit of a novel tool to be able to study surveillance for antimicrobial resistance, and that's using the environment in general, but very specifically the built environment. Neither of us have any conflicts to disclose. I'll be speaking first about sort of environmental surveillance for AMR in general, and then a bit of the work that we did during the COVID-19 pandemic on built environment surveillance, specifically in that case for SARS-CoV-2. And then I'll hand it over to my colleague Derek to talk very specifically about work being done both in our group and more broadly on AMR in the built environment. So we're here at an AMR Symposium. We all know that this is a really important issue facing healthcare today. We've talked about Christopher Murray and his group's 2019 estimates of the morbidity and mortality associated with AMR. And I just wanted to point out that that same group has published again in the Lancet their mathematical modeling projections out to 2050. And not terribly surprising, both the overall numbers and rates of deaths attributable to antimicrobial resistance look like are projected to go up. The one good news story is that in the age group under 5, this is projected to go down and plateau, but unfortunately that's going to be matched by increases in AMR deaths in that over 70 age population. And of course, as you can see in the 2019 data, AMR is disproportionately affecting certain parts of the world, so in the green there in sub-Saharan Africa. So why study environmental surveillance? Again, we've heard over and over these last 2 days about the One Health approach, so looking at the environment, animals, and humans. Very simply put, humans contribute our antimicrobial resistant pathogens and antimicrobial resistant genes into the environment. And then likewise, we can take up those pathogens and those genes from the environment, whether that's through our food or water supply or recreational swimming or nosocomially through healthcare. But I also want to point out that the environment itself can act as a reservoir for the development and propagation of antimicrobial resistance. So where we have antimicrobials released into the environment and other chemicals and naturally occurring substances can lead to selection pressure, promoting antimicrobial resistant organisms. And the environment also acts as an enormous reservoir for antimicrobial resistant genes and the mobile elements that can transfer those genes from the environment into pathogens that may be of human interest. And so the point of all of this is that both geographically and temporally over time, we can be tracking the trends of AMR in the environment, and this could potentially act as an early warning system for the emergence of AMR threats. So there's both culture-dependent methods, and I think we'll mainly be speaking about the culture-independent methods. So using things like quantitative PCR to look for specific bacterial pathogens and specific antimicrobial resistance genes. I didn't mention here sequencing, but sequencing a known pathogen to look for potentially new antimicrobial resistant genes. And then metagenomics, which in this world of environmental surveillance could mean taking a whole sample and looking at all the microbes within that sample, and perhaps better understanding the relationships and the interplay between those microbes within a community. So all sorts of things can and have been sampled. I think in my bullet list, it really goes from kind of the farthest from humans to the closest to humans. And so if you think about the natural environment, soil, groundwater, air, and if you go to places in the world like the Arctic where there's very little human activity or human influence, there you can get sort of a sample of baseline rates of AMR and the types of AMR baseline. And then as you come closer to sort of the human environment, you get more and more influence of the humans into the environment, and then the potential risks back to us from the environment. So I won't go into agriculture and aquaculture, but certainly that's part of the One Health approach. I do want to highlight a little bit wastewater and the built environment, because they're quite complementary, but there are some differences, and I think there's some key places where the built environment can address issues that wastewater can't. And so we certainly all became familiar with wastewater during the COVID-19 pandemic, and it was very useful in telling us, say in a city, what the rates of SARS-CoV-2 were looking like in that city. You could get down to, say, a neighborhood level, and theoretically, you could even be testing wastewater from a specific building, but it still doesn't tell us what's happening within that building, and that's where the built environment can come in. Other limitations of wastewater are just that it's logistically difficult. You actually have to access the sewer system, and you're dealing with now raw sewage. And so you'll see in my next slide about the built environment that it logistically is actually quite simple. And where I mentioned mobile and non-mobile elements, so we can think about things like transportation networks, shipping, airplanes, where we might have really fast, in today's day and age, transmission of these things. So our group really was looking at built environment detection, and it was during COVID really to bridge that big gap between wastewater surveillance and then, if you'll recall, like widespread human testing. So whether that was all patients on a ward in hospital or everyone coming into a long-term care home, that was human testing that was costly, invasive, as the years dragged on, became less and less palatable to people. So our method is very simple. There's a swab, there's a little tube of media. That's one of our CUBE research team doing a little 2x2 inch square on the floor, pop it back into the media, send it off to the lab. So logistically, it's very simple. It's not invasive. And it's spatially refined, so you can kind of go anywhere with this technique. So if you take a hospital, for instance, now you can start to look at individual wards within the hospital. If you were talking about a school, you could look at individual classrooms within that school. And what we said as a study was, does finding whatever it is we're looking for on the floor, does that correlate to the human burden of disease within that space? It's reproducible, it's rapid, and then we hope that these results would thus be quite actionable. So our group is called CUBE, Coronavirus in the Urban Built Environment. We've tested in lots of congregate living and learning and care type settings. We have a website that you can go to learn more about our techniques, but it's basically what we said, and most of our samples we've been processing through qPCR, but we also have the ability to use multiplex sequencing and metagenomics. I'm going to go very quickly through our COVID work to date, just to set the stage for what Derek will talk about. So in our very early foundational work, we just showed that, yes, you can find SARS-CoV-2 virus on a multitude of surfaces, and we can find it at very, very low levels, which is important when you're talking about environmental detection versus, say, a human who's infected, who we would expect to have lots of viral copies. The second thing was that we found SARS-CoV-2 where we expected to find it, in COVID units, and we didn't find it where we didn't expect to find it, say in non-COVID units or in public areas. And then by and large, our positive swabs were from the floor, rather than high-touch surfaces, elevator buttons, that sort of thing. And so that supports the idea that the floors act as a sink for our respiratory viral particles. Moving on to long-term care homes, which were obviously very affected during the COVID pandemic, we found that SARS-CoV-2 on our swabs was correlated very strongly with COVID-19 outbreaks. So here are 10 long-term care homes that experienced outbreaks during our study, the red part being the outbreak, the blue being not an outbreak, and you can see that the swab positivity went up during the outbreak. And actually, the swab positivity started to rise about 5 days, up to 5 days before an outbreak was called. And so this, again, another potential use is an early warning system. And then likewise, the swab positivity declined when the outbreak was over. Going back into acute care in hospitals, the blue or turquoise line is the number of patients admitted to hospital with COVID, and the purple is the swab PCR detection. At this point, we weren't using swab positivity, we were using CT values to discriminate. But it matches, almost perfectly mirroring what we found on the floor with what was going on in the humans in that environment. And then in the bottom graph, you can see that our swab viral biomass was lower when there was no outbreak and higher when there was an outbreak in both of those hospitals. So I call this future directions, but actually our team has been doing work already with things like RSV, influenza. We're obviously turning our attention now to the H5N1 threat. We're looking at whether this could be a surveillance method for tuberculosis, especially in communities where testing is difficult to access. We have looked at MRSA and VRE, and a CUBE member had a poster on this yesterday. And then I'll hand it over to Derek to talk about our work with other bacteria and AMR genes. This is the group. We might have missed somebody. I don't know. We are really proud that we've had lots of trainees and lots of highly qualified personnel come through the CUBE team, but it's a diverse group with evolutionary biologists, bioinformatics, clinicians like ourselves, and so it's been a great team to work with, and we're very grateful to all of the funders who have funded our work to date.
Thank you. Thanks so much, Caroline. So now that we've heard a little bit about the built environment and testing approaches, I'm just going to take us a little bit further down to focus in on AMR and the built environment. So with respect to AMR and the built environment, we're interested in AROs, antibiotic-resistant organisms, and we're also interested in antibiotic resistance genes. So AROs and ARGs. These can be present in any physical space. With some exception, we'll largely be talking about institutions, such as hospitals and long-term care. And then we're also obviously interested in the residents and people within these spaces. So within hospitals, we're interested in largely the patients, but also healthcare workers and other individuals, or long-term care home residents. Historically, built environment detection has largely been focused on reservoirs, so identifying sources of infections for patients. And that's still a significant interest and something that I'll describe. But we're also interested in the reverse, which is the human patient microbiome and its impact on the microbiome of the physical space, because that can be used for different reasons. But what we're particularly interested in is the potential for it to be used to help guide management as well. So there's really these two directionalities here, which I'll kind of bring up as we go through. So I guess first is, what can we do with the built environment? This kind of gets back to those figures, but historically, infection control was seen as one of the major applications for understanding reservoirs of pathogens within the built environment. So can we identify AROs within these spaces? Probably the most well-known would be the identification of multi-drug resistant gram-negatives from sinks and the potential for causing infection with patients within those physical spaces. Identifying routes of transmission, and then obviously related to this, when we can try to find these reservoirs, how do we potentially mitigate them? But as I alluded to, there's also the potential to inform patient treatment. So could we define ecologic risk? Just being in this physical space, in this ward, in this unit, does that put the patient at risk for infection for a particular type of resistant ARO, for example? And then you can go even further and say, well, if I know what's happening within this patient's room or within the direct physical space, can I know what's happening with them, either their risk for something happening or the characteristics of the infection that they currently have. So I'm going to review just a few of the kind of recent seminal studies which have kind of looked at the built environment and AMR. A lot of them using the kind of some more of the modern techniques related to metagenomics and sequencing, with some of them culture-based. And then I'll highlight some of the work that CUBE is doing and where we want to go. So I think I don't know if people are familiar with this study. This is it's getting a few years old now, but this was a very innovative study. It was a large study looking at essentially the microbiome and resistome of the urban environment and mass transit systems across the globe. It's called the MetaSub study. It was performed across 60 studies over about a 2-year period. And people went and they swapped surfaces within subways, kind of mass transit centers, generally high contact surfaces. And then they performed metagenomics on the samples. So looked at the biomass that was collected, and they sequenced the pieces of the DNA there, and tried to identify organisms and genes from there to learn what was around us in these places that are commonly visited by all of us. What they found, interestingly, was there's a common taxa, so there's a common set of bacteria and microbes that were present across almost all of these cities, and that's likely reflective of human microbiome that's often common to all of us. But they also found a huge number of antibiotic resistance genes with the potential to impact or reflecting a large number of antimicrobial classes that we commonly use. And not only did they find these genes, they also found that there's very significant heterogeneity of distribution. So some cities, if you look in the figure on the right, at the very top, that's Bogota. Bogota had the highest prevalence of AMR gene types. You compare that down to Stockholm, which had the lowest, almost 20, 30-fold difference. So this was a cool study because it kind of made us realize there's how much antibiotic resistance genes and organisms are around us and in the physical environment. So now I'm going to move a little bit kind of focused into the hospital setting, which we'll spend most of the rest of the talk focused on. This is a very cool study from 2 years ago, which asked the question, kind of what is the microbiome of a new hospital space? The opportunity here was there's a new ICU being built at this tertiary care institution in Washington. And they said, well, let's see what organisms and antibiotic potential MDROs are present in our ICU currently in the physical environment, and let's see what happens when we build a new ICU and before we put patients in there and after patients are admitted. It was very, very cool. They swabbed contact surfaces, kind of light switches, bed rails, some floors, but then they also looked at sinks. As I mentioned earlier, sinks can often be a source for biofilm-forming organisms that can potentially cause infections. And so they looked at both of these surfaces. What they found was with the old ICU, those are the purple bars there. If we look at maybe the sinks first, that in the old ICU, there's a high burden of bacterial isolates from these sinks, essentially. And when they went to the new unit, that decreased. That was, I think, kind of expected. But then when it started to admit patients, the sink kind of composition didn't really change much. Interestingly, they found that a particular sequence type of Pseudomonas was present in the sinks in the new ICU even from the onset, before patients arrived, and it continued after the arrival of patients, and was persistent amongst all of the rooms tested, and a number of individuals or patients developed clinical infection with this particular sequence type. So that's reflecting that directionality from the physical environment to the patient. If we look at the other surfaces, the other one or higher contact surfaces, there's the same general trend from old ICU to new, kind of a lower burden. But when patients arrived, that increased, and that again likely reflective of the kind of the patient to human microbiome, not just from patients but also healthcare workers as well, kind of influencing on the microbiome of that and resistome of that physical space. This next study was kind of like that original meta-sub study, but it was looking at what they called the cartography of AMR in the hospital. So they really wanted to try to map out the AROs and ARGs within a single institution. This was done in Singapore. That was a group that participated with meta-sub. And what they did was they sampled, again, physical spaces within this hospital consistently over time. And there's, again, differentiating the surfaces that they did sample. And they wanted to understand, is there some natural kind of clustering of the organisms that are there and the antibiotic-resistant genes and AROs that are present by the locations? And what can that tell us about the distribution within the hospital? So if you look in the bottom left-hand corner, it's principal component analysis, but you can see there's kind of clustering there of some green and then some kind of pinkish points, and those represent the kind of separation, a taxonomic separation of samples from either the common biofilm forming areas like aerators and sink drains versus the other kind of more higher touch surfaces, which they felt represented more of the human microbiome. And this is consistent when they looked. You can see in the middle figure there, the left two columns. These are just all of the ARGs that they looked at using their sequencing, and there's a significant different distribution of ARGs when you compared these kind of biofilm locations versus the other contact surfaces. So this really reflects, I think, what we've seen the last two papers as well, which you have this natural separation of taxonomic makeup and antibiotic resistance gene and ARO groupings by physical site within the space. The last study I want to highlight is actually a study locally from Sunnybrook, as Jerome Leese and his team put this together. I thought this was a very cool example of the physical built environment acting as a potential source for infection, maybe outside of the sink example. And what this was is they had a VRE outbreak at one of their units, and this was during the pandemic. For pandemic-related reasons, they actually ended up having to move that whole group, including the healthcare workers associated with it, to a different physical space. And so in the midst of the outbreak, so they did this, and actually they moved another surgical unit into that previous space. When they did this, the patients who had been within the outbreak, and when they were in the new space, no longer developed new acquisitions of VRE, and whoever moved into the previous outbreak space started to develop acquisitions of VRE, and then actually a month later they switched again, and it reversed back to the original scenario. So really kind of hinting that the acquisition here of these cases were related to the physical space itself, not the patients or the healthcare workers associated with it. They did try to do some environmental sampling unsuccessfully, but beyond that, very, I think, strong case for that reservoir and directionality. So kind of focusing now on some of the work that we're doing with this group, CUBE. I'll highlight a little bit of work here. For instance, Dr. Laura Hug from Waterloo, and so she's done some preliminary work looking at applying metagenomics to low biomass specimens from the hospital environment. And so we have a number of floor specimens from a tertiary care hospital collected at different locations from, broadly speaking, hospital clinical care units and public spaces. On the left-hand side, you can see that this is kind of a distribution of pathogens that have been isolated predominantly, and again, these are from floor samples, so we're predominantly finding kind of human microbiome-associated organisms, which we kind of expect and which we might see from the previous studies shared. And then we looked specifically at some relevant resistance genes, including MEK-A and VAN-A. We see that they tend to they're more prevalent and cluster within the clinical spaces compared to the public space. So differentiation of the antibiotic resistance genes and potential AROs that we would find there. What we wanted, our plan is to essentially apply a similar approach as that AMR cartography paper, but trying to link it even more with clinical outcomes. So not just, where are the ARGs and where are the AROs, but how do they relate to the infections that are experienced within these spaces and these units and on these wards and by the patients there. And so that's our eSharp project with Alex Wong from Carleton is leading. And we have some bridge funding from CHR for that project. But interesting, one key piece of this is trying to improve our metagenomic approaches, improve the efficiency of our metagenomic approaches. We're most interested in the AROs and ARGs. Problem is when you do these samples and you do metagenomics, you're sequencing all sorts of different DNA, most of which you aren't interested in and don't care about. So and you spend money and time and resources on these things that you don't need. So one way to improve this is to use targeted metagenomic approaches. Alex has been looking at a kind of pull-down approach where you pull down the genes of interest and then you're able to sequence those. So you improve your sensitivity at less overall specimen depth. So very appealing there. This is just some initial data that we have from that. Again, these are from floor swabs within a tertiary care institution. And I'll just highlight, so on the left there's resistance genes, and it's grouped by hospital public areas and clinical areas. And generally we see within the public areas there's a kind of a consistent distribution of similar genes, whereas once you get into the clinical area you see a greater abundance of certain types of antibiotic resistance genes that are more potentially clinically relevant and may reflect the differences in selective pressures on these clinical units. I'd like to highlight another project which we're just getting underway with, being led by Dr. Michael Freilich here in Toronto. And this is, again, trying to link some of the built environment detection with kind of clinical infection. We're particularly interested in bacteremia in level 3 NICUs, so high-risk neonates with bacteremia. There's concern for the potential for environmental transmission in terms of etiologies for infection, but also a strong desire to get as much information as you can about infections that might be happening and help guide treatment. So we're actually just starting this project. We'll be doing metatranscriptomics from a number of surfaces within rooms of neonates with bacteremia, and we'll be looking to see whether that can provide us useful information about the actual infecting bacteria. So stay tuned for that. And then I don't want to go too much into this. It's actually presented as a poster, but we've also done some prelim culture-based work looking at the detection of VRE and MRSA from the environment or in patient rooms for patients who are colonized with MRSA or VRE. And that's Alex Hicks, and it was presented by Patricia Olar here. So without stealing too much of their thunder, generally you're seeing some concordance there between what the colonization of the patient and detection, which is good. Lastly, I'll highlight some work by Dr. Reese Casson. It's actually focusing more on the bioinformatics related to built environment detection. So this is through a Genome Canada-funded grant, and it involves the game Borderlands. I don't know if anyone's played it. I don't think anyone's seen the movie. And essentially, it's a game within a game. So people who are playing the game, they can play another game within this game. And when they're playing that game, they're supporting essentially some of the assembly and alignment of metagenomes. So it's really kind of a cool thing to look at. But they'll be using built environment metagenomic data to do that. So it's kind of a project we're really excited about. So I think to hopefully summarize the talk, environmental surveillance is increasingly being used for AMR-related infection control and clinical applications. Built environment detection has demonstrated promise for localized detection of both environmentally entrenched AROs and ARGs, as well as human microbiome-related AROs. Has the potential to guide mitigation for environmental source AROs and provides opportunity for spatial assessments of individual patient risk of ARO infection in institutional settings. So there's obviously a lot of work that needs to be done in this area, and there's lots of opportunities. And if anyone's ever interested in collaborating or working with a group, we'd be happy to do that. So thanks so much.